Clary Wiholm, who comes from Stockholm in Sweden. Her background is medicine, but she's gone into social medicine, and she's going to talk about RESHAM. We call it RESHAM? Okay, a national research program in Sweden enhancing return to work.
Thank you. Can you hear me? Good. Ladies and gentlemen, I'm very pleased to have been invited to join this workshop and to present for you a Swedish initiative to increase well-being, work capacity, and return to work in patients suffering from unspecified pains and from mild to moderate psychological ill health. In the beginning of this century, Sweden faced, as very many other countries, a very rapid increase in sickness absence due to this diagnosis. And in order to break this upgoing spiral, different kind of activities were taken. Probably the most powerful were changes in the social insurance with new limitations for work capacity measurements and also limited days for sickness absence. In order to stimulate the practical clinical rehabilitation work, the Social Ministry of Health and the Swedish Association of Local Authorities and Regions, this is a difficult word, SALAR, and it's an organization for the county councils in Sweden. They introduced a promotion program, and this program is called Rehabilitation Guarantee, and aiming to support people suffering from diagnosis anxiety, depression, stress-related disorders, and musculoskeletal pain. These people had to be already on sick leave or at risk to be sick listed. And the purpose with this rehabilitation guarantee was to prevent or to reduce sickness absence, to offer early interventions, rehabilitations, and rehabilitation measures had to be evidence-based. And there are 3 points that are very specific in the guarantee. The methods had to be evidence-based, and the rehabilitation should start as soon as possible based on medical evidence or evaluations, and the target group is working people. Yeah. Oi, what happened? So RESAM is a national-wide research program, and it is a part of the rehabilitation guarantee. And the purpose with this research program is very easy, actually, to find the best methods in retaining and restoring work capacity in people suffering from this kind of diagnosis. And the evidence-based treatments recommended from Swedish Council of Health Technologies assessment, another difficult word, is for mental health issues, cognitive behavior therapy or similar. And the evidence that we have for this kind of treatment are that there is effects on symptoms, there is positive effects on function, but there are actually no evidence that cognitive behavioral therapy or similar really help people back to work. And for musculoskeletal pain, as we have heard here before, it is multimodal rehabilitation. And there are also evidence that it has an effect on pain or symptoms, it has an effect on function, and there are also some evidence that it do support people back to work. So, in order to enlarge the evidence-based knowledge of what kind of intervention within multimodal rehabilitation and in cognitive behavioral therapy interventions or similar, do have a documented effect on work capacity and return to work. The Swedish Ministry of Health allocated around 100 million Swedish crown, and I have tried here now to convert it to euro, and I think it is 12 million euro, approximately. for research within this area. And the National Agency of Social Insurance, where I work, got the commission to handle these applications for funding, and also choose those projects that had a high quality for funding. Research is not a normal program. It has taken a somewhat new approach by pointing out the county councils as main applicant for the research programs or the research projects. But however, the PIs, the project managers, have to be or has to be a senior researcher affiliated to the university. There has to be a very close collaboration between the county councils and the universities. And the reason for this constellation is that the county councils in Sweden are responsible for most of the healthcare, and especially the primary healthcare. And this method should, after a while, hopefully be implemented in the primary healthcare, and the patients for these projects are also to be found out in the primary healthcare services. So that's why we had this constellation, to make the county councils main responsible. We have focused on mainly interventions, but we have also approved some methodological studies. Other requirements are that there has to be a genus perspective on the intervention. How does it impact on women? How does it impact on men? And so on. The studies had to be controlled, not necessarily randomized, but controlled. And we have also required that the projects have to present a cost-effectiveness calculation in the end of the interventions. What would a change to this kind of intervention that maybe shows that it has a good impact on work capacity, what will it cost compared to what we are doing today? And then, furthermore, we have required a manual, a guideline, with very practical information, what has happened in every session in this program, aiming to support other colleagues to try to implement and adjust it to their own work. And in order to promote high-quality research, an expert group was formed with national and international senior researchers. And the expert group had to evaluate all the applications and also recommend which projects should be funded. And actually, only 18% of all the applications were recommended to be funded. And most of these projects are partly funded, not fully funded, because it is also expected that the county councils should contribute with cost or with labor. It's very small. The program has had 3 calls. The first one was in 2009, and the last one in March 2011. Totally today we have 24 projects running all around Sweden, as you can see on these small spots. And approximately 50% of the projects are focusing on multimodal rehabilitation interventions, and 50% are focusing on cognitive behavior therapy or similar. But as we all know, there is really no straight limit or between pain and mental ill health. Many of these patients go over time between these diagnoses. And many of these patients who are treated in a pain group also have mental disorders or cognitive disturbances, as we have heard here before. this kind of program, where you have project teams all over the country, where you also have a collaboration between people working out practically on in the rehabilitation work and researchers, opened up to establish a national-wide network. And during the project time, these networks have the opportunity to meet, not only when they're doing their working in the project, but also meet together because we have a special program for this network. We also understood that this new approach to conduct research might be complicated in the beginning, at the start, because the county councils and the universities, they had totally different culture, they have different goals and also administrative routines. So in order to facilitate the process to get these people together in a good way, we decided to start what we call a knowledge sharing program. And that means that during the 2 years of project time, because the projects are funded during 2 years, and they should also include 1 year's follow-up. And I will come back to that in the end. And a big part of the program has been focused on communication and communication training, because researchers, they need to learn how to communicate with people, with stakeholders, with potential participants. And restoring and retaining work capacity and return to work is something that is very important for all of us. And what is important for many people, it's also important for journalists. And RESAM has all the criteria to be really good news for the journalists. So it's very important that those people who are working in the projects know how to communicate and how to communicate with media. So the communication program goes on for a year, and during this time, the teams learn communication skills and media training. We have also offered workshops in cost effectiveness calculations for those who don't have health economics involved in the projects. The first National RESAM Conference was held last year in May, and the conference gathered different kind of competencies, researchers, practitioners, decision makers, politicians, and all the projects, all these 24 projects had opportunity to present what they were doing. They had no results, but what they were doing, either as an oral presentation or as a poster. And what do we have for the moment? It might be difficult to see, the text is so small, but we have approximately 5,000 people involved in RESAM projects. And 2,000 of these are involved in multimodal intervention programs, and 3,000 in some kind of cognitive behavior therapy interventions. The interventions that are evaluated are very many, and one example could be improved communication and problem solving that are added to, for example, a multimodal rehabilitation program. Acceptance therapy compared with cognitive behavior therapy, that could be one kind of project. Improved body awareness for people suffering from neck pain due to visual problems. There is also one project looking at multimodal rehabilitation with only one caregiver compared to the team. And we have also different kind of web-based multimodal rehabilitation programs, and there are many others, but the time doesn't, I cannot tell them all. We have studies that are focusing on prevention studies, what can do that people really don't get sicklisted. We have projects that are focusing on those who have been medium or on a long-term sickness. And then we have some projects that are focusing on those who has been really, really long time away from the working life due to sickness. I think it's somewhere between 6 to 10 years in one of the projects that there are patients that are now try to get closer to the labor market. It's important to say also that the compulsory exit criteria in this program is work capacity and return to work. Other measurement, well-being, health, are very welcome, but they are secondary outcomes in this program. The research is conducted in the primary health care, in the occupational health, and also in some projects in special clinics. But what's most interesting, actually, is that now we have the opportunity to scientifically evaluate these kind of interventions that already exist out in the practical healthcare, to really find out if they have an effect not only on well-being but also on return to work. And that is quite exciting, I think. I was also asked, yes, can I say something of success factors? Yeah, but I don't know what happened. Could somebody help me? What is it said? It's too small, even. No, next one. No. So, but I can say that some success factors, I mean, it might be too early to really be sure, but probably is that this was a governmental initiative, and there was a very broad agreement with the county councils, and also that there is a limited knowledge body of evidence what do bring people back to work. There were also a lot of challenges, but I don't have time to go into that, because I would like Christina to give us 2 or 3 minutes so I can present some voices from the program. Thank you, Christina.
Mr. Kristersson, why did the Swedish government decide to finance Resam?
Well, basically because there is a lack of knowledge and evidence-based research that goes into the practical social work when it comes to helping people back from sickness leave back to work again.
Professor Linton, what is the main focus in your project?
We work with early intervention for people with musculoskeletal pain problems, and we're out in the workplace working with both the workplace and workers.
What have you found so far?
We have been able to identify people very early on with back pain and neck pain. We provided them with a cognitive behavioral approach both to the supervisor and to the individual suffering the pain. And we found in our preliminary results that this has quite a large effect on a number of things. One is the risk to develop long-term problems, and the other is on actual sick leave.
Well, my research is about Iraqi refugee women with persistent pain. This is a vulnerable group. Many have suffered from trauma and abuse in their home country. They've had to escape and resettle in a strange part of the world. This means an enormous stress, which affects the health, both physically and mentally. The aim of this project is to develop, you may call it a toolbox, for the professionals within primary health care in order to be able to offer these women sufficient treatment or rehabilitation according to their specific needs.
The main focus in our project is to evaluate a web-based complement, an educational program that is a self-management program as a complement to multimodal rehabilitation.
What can you say about the importance of a research program like Resam?
Well, it's really vital because as a researcher, we can sometimes get money to do our studies, but the real problem is transferring what we know about these things to actual practice. And RESOM has focused on implementation, so we work very closely with the community and with health services, and so this is something that we believe will be very applicable and that one can pick up in primary care and in occupational health care.
The more we can connect practical social work on the field, so to speak, with frontline research, the better. We have done that. We haven't been so successful so far in Sweden, is my belief. So all platforms and places that connect these knowledges and these professions to each other is of real importance.
Thank you very much.